Our next session is on optimization of skeletal health in diabetes. I call upon the moderator, Dr. Dheeraj Kapoor sir, for moderating this session. Experts for this session would be Dr. Beatrice and Dr. Rajat Gupta.
Well, thank you so much, organizers, for involving me here. And we do understand that diabetes and bone are not linked very frequently. And when we were students, diabetes and liver, if you look at Sheila Sherlock at that point in time, there was just one paragraph. And now you have a whole book on liver and diabetes. So who knows, maybe that in future we may have the same as regards diabetes and bone. I welcome my colleagues and my team, Dr. Beatrice from Hyderabad and Dr. Rajat Gupta from Panchkula, Chandigarh. Let us start off with Dr. Rajat. So what exactly is diabetic osteopathy?
Good evening, everyone. Thank you, sir. So, diabetic osteopathy, as we know, diabetes affects all the organs by and large in the body, directly or indirectly. So it has been seen that the bone quality is poor in diabetic individual, irrespective of the BMD, as we assess commonly with DEXA scan or with other mechanisms. So poor bone quality in terms of, it's basically in terms of quality, not quantity, and then leading on to fragility fractures, low trauma fractures. So this is vaguely has been termed as a diabetic osteopathy.
So what do you feel? Is it a microvascular complication or a macrovascular complication?
Yes, multiple mechanisms are there. So various things basically lead to diabetic osteopathy or poor bone health, but definitely it's part of microvascular sort of insult of diabetes on bones, not the macrovascular one. Though it's basically a combination of all the things put together, more for microvascular.
So possibly microvascular, and I would wish that the audience at any point in time could raise their hand and ask the questions to the respective speakers if they deem fit. So having said that, Dr. Beatrice, what changes do you expect in BMD of a diabetic patient? So a very variety of patients, type 1 diabetes, type 2, secondary. What changes do you expect in BMD of these patients?
So there are certain common features which sort of link in the different types of diabetes. The type 1 and type 2 diabetes, the pathophysiology is the same and different. So there are some common features. So let's, there is hyperglycemia, which is the primary factor. There is chronic hyperglycemia, uncontrolled diabetes. So that is going to be the primary factor. So there's going to be a lot of accumulation of advanced glycation end products, which are going to form cross-links with the collagen in the bone, and there they're going to in fact increase the skeletal fragility. And like Dr. Rajat had just mentioned, it's also there is going to be changes in the microvasculature as well. And of course there is chronic inflammation in both these conditions. Having said that, we do not expect the same BMD, and what the studies have shown is in type 1 diabetes there's in fact a decrease in BMD, whereas in type 2 diabetes there is an increased BMD, but both of them have increased skeletal fragility. So what could be the possible reasons? In type 1 diabetes there is insulin deficiency, so there is low insulin levels, and we know that insulin is also an anabolic hormone and it promotes growth. So the bone is sort of deprived of the growth factors. So that is one reason, and the other possible reason could be that type 1 diabetes is going to present at a much younger age than type 2 diabetes. So there is going to be interference in the acquirement of your peak bone mass. So that also is going to have an effect, and that is probably one of the reasons that why the BMD is lower in patients with type 1 diabetes. On the other hand, if you look at type 2 diabetes, there is hyperinsulinemia. So there is going to be increase insulin in the blood, which is going to act through the IGF-1 receptors which are present on the bone, and this is going to promote growth and differentiation. And we know that type 2 diabetes is also associated with obesity. Again, an area of chronic inflammation, and there is also going to be increase in the leptin levels. Again, leptin sort of promotes the osteoblast action and reduces the osteoclast action. So all these factors could contribute to an increase in the BMD in type 2 diabetes.
So a word or two about secondary diabetes, maybe FCPDs or the hyperthyroids or the Cushing's, a word or two about that?
Yes, sir. Pancreatic diabetes, of course, we know that there is a whole lot of other things which is happening other than the hyperglycemia. There is going to be malabsorption. There is no data as of now looking at bone health in FCPD. But what we could theoretically assume is that there is malabsorption, there is going to be vitamin D deficiency and fat malabsorption, and these people are very lean as well. So you know that the BMI is also going to be on the lower side. So there could be increased skeletal fragility in these patients, but not being studied on a large scale. If you look at secondary diabetes, let's say Cushing's, of course there is going to be a decrease in the BMD because of the effect of glucocorticoids on the bone. If you look at conditions like acromegaly, again, that is also a form of secondary diabetes. So that is, again, there's going to be increase in the growth hormone levels in the blood. So there is an increase in the BMD, but there is an increase in the skeletal fragility because there are also associated factors that we need to consider, like hypogonadism.
So Dr. Rajat, she's been saying again and again that diabetes, you have a better density and yet more fragility. So are we to believe that FRAX score isn't good enough for diabetics? Does it underpredict or overrate the fracture risk?
So FRAX score basically has been devised because not for all patients BMD simply can predict the fracture risk, because two people can have same BMD levels, but because of other factors they all can have different fracture risk. So this algorithm basically contains age, gender, BMI, and it also corrects for steroid intake, it also corrects for smoking and also alcohol. There is secondary osteoporosis, there is one column in this which includes type 1 diabetes as well. So it does sort of corrects for type 1 diabetes, but there is no mention of type 2 diabetes in FRAX score. So FRAX score is a useful tool, but somehow it tends to underestimate the fracture risk in both type 1 and type 2 diabetes, because type 2 even it's not been mentioned in FRAX scoring, so it would definitely not sort of assess the risk which type 2 diabetic of the same age, gender and all those things would have compared to non-diabetic individuals. So probably it would underestimate.
So now FRAX score is not good enough. So are there any tools with which we can have the aid how to predict? So any investigations or tools, Dr. Beatrice?
Yes, sir. Since the FRAX is not really an accurate tool to tell us whether this patient with type 1 or type 2 diabetes is going to fracture in the future, we do have studies showing trabecular bone score and trabecular bone score adjusted FRAX, which are coming up in a big way, in fact, to look at the fracture risk or predict fracture risk in patients with diabetes. But unfortunately, TBS is not available all over the world. I mean, at least in India, it's not available everywhere. So, we lack that data. And peripheral quantitative Ct, again, is another tool which is being studied, especially in type 2 diabetes, where they have looked at the radius and the ulna, and they found that there is increased cortical porosity. Again, that could help us. And in fact, in our own institute, we are doing a study on that. And other markers, and there is another tool, a handheld tool, which looks at the bone indentation. So it looks at the resistance of the bone to indentation. That is again something which is coming up and which could be used in the clinic if it is validated. And blood markers, if you ask me, sclerostin has been studied in patients with diabetes because it's found to be increased in patients with type 2 diabetes. And there are a few studies looking at advanced glycation end products, again looking at fragility fractures and increased fractures, but all these need long-term studies.
So having said that, Dr. Rajat, first of all, BMD, right? That's a basic. Now, many people would believe that radiation is an issue there. So what do you have to say about BMD and the radiation? I mean, just to clarify for the audience, is that as bad as we believe?
No, sir. BMD actually, the radiation exposure is 1/10 of the simple chest X-ray. So radiation exposure with BMD is very less. On the other hand, if you do QCT, though it is not available everywhere, it's basically sort of more of a qualitative indicator, microarchitectural indicator of bone, while BMD is basically more of a areal density. So there is a difference between BMD, which is areal, which we do with DEXA scan, which is gram per meter square, and the done with QCT is basically volumetric BMD. So in general, again, I would not say BMD is not a useful tool, but if it is normal, we can't exclude the risk of fracture. But if it is low, definitely it gives you sort of information, yes, this patient is at the risk of fracture. So the only normal BMD would not sort of exclude the risk of fracture, but obviously if you have low BMD, if you have osteopenia or osteoporosis on BMD, even then it would sort of tell you that this individual has high risk of fracture. And even there have been studies which have basically tried to find out at what BMD level is equivalent for a non-diabetic individual. So it has been adjusted and studied that if you say keep 0.5 less, so meaning thereby if you have T-score of close to 2, that is equivalent to close to 2.5, minus 2.5 for a non-diabetic individual. So if you have a diabetic individual with a BMD score of minus 2 T-score, so that means it's probably as bad as having a minus 2.5 with a normal individual. So it should be helpful. Only thing is, if you have normal BMD, that doesn't exclude the risk of fracture.
So we could assume that -2 broadly could be the starting point for treatment. We could assume that.
Yes.
That is fine. Now the issue, what is the role of glycemic control on your bone density? So anyone, if you could take that up. How does glycemic control, and by what mechanism would it?
Sir, yeah, as Dr. Beatrice has already said, the glycemia is basically at the center of diabetes. So the advanced glycation end products. So whenever there is a glycation of collagen, which leads to sort of abnormal matrix formation, which is quality-wise poor matrix, and that will not have same strength as a normal matrix would have. Also, indirectly, these advanced glycosylation end products affect osteoblastic functions and their differentiation and conversion of progenitors to osteoblasts. So, if you control the glycemia well, obviously, mechanistically, it should help in reduction of fracture risk.
And of course, there are studies to show that osteocalcin synthesis is reduced by hyperglycemia. So that could be one mechanism.
And other factors also, so like sarcopenia, we were just studying. Sarcopenia is there whenever you have poor glycemic control, propensity to fall is more. So all these things also contribute to fracture. So one doesn't break until unless one falls. So the prevention of fall is as important and making the bones strong. So that is very important.
So we've talked about glycemic control. Now there are drugs which are used for glycemic control, right? So what about drugs which are not bone friendly, as we may call them, from the diabetes perspective, anti-diabetic drugs which may impact the bone adversely? Dr. Beatrice, we tell?
Yes, so we'll take each drug, like the commonly used drugs, not only the not bone friendly drug. We do have studies on other drugs as well. So the commonest and the first line drug that we use is metformin, and metformin is going to improve the insulin resistance. So metformin has found to be beneficial in these patients, so at least not bad. On the other hand, we have drugs like Pioglitazone, which has been associated with an increase in the fracture risk, and this is because Pioglitazone is going to act through the PPR gamma pathway, and activation of this is going to sort of push the mesenchymal stem cells into an adipocyte lineage. So there's more fat formation and less of the bone formation. So this is going to contribute to the bone fragility, and this is what has been shown in the studies where people or post-menopausal women especially who are using Pioglitazone were found to have increased incidence of fractures. So we need to exercise caution, especially when somebody is at a higher risk of fracture. We need to exercise caution when we start them on Pioglitazone. And we have newer drugs like SGLT2 inhibitors. Again, we have been debating about the fracture risk in these patients because of the Canvas trial, which showed that there could be increased risk of fractures in patients who were on canagliflozin, but it was not reproduced in the other canagliflozin trials like Credence. So still the jury is out there when it comes to SGLT2 inhibitors. They could have hemodynamic effects, they could have increased risk of falls, they could probably increase the phosphate levels in the blood because of the action through the kidney. So that could increase the parathyroid hormones in the blood, and that could probably have an effect on the bone. So these are all theory behind it, but we need long-term studies to look at the fracture risk in these particular patients.
Great. So, pharmacology done, exercise. What is the role of exercise, and how do you think it would impact beneficially on these patients, right? So, both of you could take it one by one.
Sir, exercise actually again, it would make the muscle strong. So tendency to fall would reduce, and especially the weight bearing exercise. So because of mechanical loading on the bones, so weight bearing exercises are more useful in making the bones strong. So someone is walking and someone is swimming. So as we know, swimming is non-weight bearing exercise. So it is not going to help that much in terms of bones. And if one is walking, so probably it's a weight bearing exercise, so it is going to make the bones stronger. Also the balance wise, if you walk regularly, so balance and all those things also become better. And then the exercise maintaining the muscle strength, obviously it is going to prevent the fall. So that way exercise is very important indirectly in bone health and reducing the risk of fracture.
Yes, I just like to add one point there. We should not be giving a blanket exercise prescription for all our patients with type 2 diabetes or type 1 diabetes. An important factor that we consider, especially in elderly patients with type 2 diabetes, is their stability, and they have an increased risk of falls. So we need to look at their stability, their muscle strength, and just like Dr. Rajat had just mentioned, muscle strengthening exercises or the anaerobic exercises again are very important. So we were just talking about sarcopenia now, which is not very uncommon in the elderly population. So they should be going for graded exercise to improve the bone health.
And Charcot's is one of the complications of walking. So we have to be careful about that also, because many patients who walk without proper shoes and they have neuropathy, the Charcot's is very, the risk is quite high, and often it is missed and often being treated as cellulitis. And it is far more common than we think. So yeah, we see Charcot's a lot of times.
Please.
Usually your patients asked at the level of 300 or 250 or 260 or 350, sir exercise करें कि ना करें अभी? I advise them not to exercise till their blood glucose level is well within control, because this adversely affect their performance in the daytime. Once you are exercising at a level of 300, walking for 3-4 kilometers, it badly affects them. And this we must advise our patient, till the blood glucose is controlled, please don't do much exercise.
You're absolutely right, sir, because dehydration would again
Yes.
make the glycemic control worse. Yes.
So, could we elaborate on the sugar levels and the ketosis aspects, since he's raised this point?
Yeah.
Can we elaborate on that one?
Yeah. So this is especially true for type 1 diabetic individuals, those who are insulinopenic, type 2 or other causes, those who have increased risk of ketosis or ketonemia. Then we should advise the patient, especially if the blood sugar levels are 250 or more, as you said. So they should be well hydrated, and sugar should be brought down to certain levels like 150. And similarly for the low blood glucose levels. So if the fasting glycemia is less than 100, the blood glucose level is less than 100, the risk of hypoglycemia also is more during walk or during some exercise. Though sometimes we have seen post-exercise blood glucose levels goes high because of sympathetic response, but sometimes it goes low also because if it is prolonged exercise. So yes, once you have extremes of glucose levels, we should advise the patient to maybe just gradual exercise or maybe 5 or 10 minutes simple walk. And then once glycemia becomes better, then gradually they can increase the exercise, yes.
And also the type of exercise matters, because aerobic exercise, they do tend to bring down the sugars, and anaerobic or muscle strengthening exercise, they tend to increase the blood sugars. So it should be a mix of both. And of course, like he had said, the patients with type 1 diabetes need to check their blood sugars before they exercise, and if it is more than 250 to 270, they need to also check their urine ketones, and if it is positive, they should avoid exercise. And we do have cutoffs. given by the different guidelines for exercise in type 1 diabetes. So ideal blood sugars will be around 126 to 170. So this is for aerobic exercise. Anaerobic, you can even start with lower sugars. Even 90 to 126 is fine.
So he brought out a wonderful point about the sympathetic stimulation. और हम सब ने सुना होगा कि मैं एक्सरसाइज करके आया और शुगर बढ़ गई मेरी. फास्टिंग मे बी 110 थी, एक्सरसाइज किया बिना कुछ खाए पिए 150. So that is a temporary rise and the patient should be assured that this is not an unusual phenomena. So the last question and one word answer from both: indications for treatment of osteoporosis.
Any fragility fracture, vertebral or hip fracture, we start treatment. In any other sort of fracture of any other patients, type 2 diabetes or type 1 diabetes patient, we look at the BMD, and the BMD through the, if it is less than T-score of less than -2, then we start treatment. Or the other way to go about it is look at the fracs. The fracs you can substitute it, you can tick the column for rheumatoid arthritis. That is another way to go about it to increase the risk. So that again, if the possibility of a 10-year possibility of developing a fracture is more, then we start treatment.
Okay, so audience, maybe a couple of questions. Dr. Luthra?
In both this lecture as well as what Sunil alluded to, we've ignored an important aspect of protein intake. You see, we are a vegetarian population. Large people are vegans and vegetarians. Especially people who exercise and don't take enough protein, it may be counterproductive. And for muscle mass, which adds to muscle strength, stability, better posture and balance, a good protein intake is very important.
Right, sir.
The cardiologist says no fat, the diabetologist says no sugar, right? So and the nephrologist may say less protein. So what does the diabetic patient do? What does he eat?
Moderation, sir.
Yes. So
Moderation.
I think the aspect of protein, particularly in type 1 diabetics, where they have stunted growths, they have insulin deficiency, they also may have celiac disease, which can contribute to malabsorption. So they can have iron and calcium deficit, they can have protein malnutrition. So the aspect of overall holistic nutrition is important, not only for musculoskeletal health, but also for bone health. Thank you.
So we take it for granted that the diet is being prescribed by the doctor or the dietitian. There is never a no to carbohydrate. In fact, we always say 50 to 60% of carbs should be there in your diet, maybe 40, but not less than that. The other is about the fats, so 7% and 30%. So the guidelines are there in place. It's just that the patients are not conveyed in the correct manner and they are explained in extreme measures. Ye bhi nahi karna, wo bhi nahi, karna kya hai? But I think a diabetologist does justice to that. So regarding protein intake, I think the point may have been missed in discussion, but I think most of us are doing it anyways as a reflex. So I'll close the session here. Thank you so much, my team, for being here.
Thank you, sir.